Shelley Lloyd was referring to there in terms of the vaccine is the man who's sitting in front of me right now, Associate Professor Paul Griffin, the Director of Infectious Diseases at the Mater Hospital. He's happy to answer your questions this morning on 1300 222 612. But Paul, good morning.
Morning. Thanks for having me.
A pleasure. We are thrilled to have you and your brain in studio each week. In terms of the vaccine, another important milestone's been passed. What's happened?
So, there's been some preliminary data that the vaccines, at least in animals, are generating antibodies, and there's a few that are doing that. So that's really good news. There's a lot of milestones we have to go through with animal studies, or I guess starting in the laboratory, then animal studies before we progress to human studies. And, we're ticking the boxes with all those milestones. So the human trials are really the next big step. And I'll be trialling one vaccine in around 2 weeks, and then there'll be the UQ one coming shortly after that.
What will that mean? What will that day be like in 2 weeks' time when you trial that vaccine?
Look, it's really exciting. I've been working on vaccines for a long time, but to be able to give healthy volunteers a vaccine for this is obviously a really important milestone. And, while there's great progress being made, every day you hear about new things, the vaccine is really what we need. So to be part of that is really exciting.
How do you do it? Is it you injecting them?
I probably won't actually be giving the injection. We have trained nurses that will be doing that, but I'll be overseeing the process to make sure that it all runs very smoothly and we look after our volunteers very well.
But it's a shot in the arm?
It is a shot in the arm, that's right. Yep.
Will you be nervous on a day like that?
No, I won't be. So if I had any reason to be nervous, we wouldn't be doing the trial, basically. So we need to be completely confident of that data supporting doing it in people before we do that. And independent reviews by ethics committees have to happen as well. So there'll be no nerves. It'll be exciting. Is
it hard to get people to volunteer for those human trials?
For some of our studies, it can be. I think for this one, it probably won't be because obviously there's, a really good reason for people to participate in terms of helping us develop this. So I would like to think that we won't have any trouble recruiting these studies.
1300 222 612. If you've got a question for Paul Griffin this morning, he's an infectious diseases physician, a microbiologist. He is one of those people who is working very hard to find a vaccine for the virus that has destabilised the world and continues to do so. Although, Paul, prior to you coming in this morning, we've been talking about rugby league and their desire to get back to normal or back to playing a version of the sport. May 28, the NRL says we're ready to go. This is despite the fact that the Queensland government at least hasn't agreed to that. The sport is likely to be on the table, on the agenda at the National Cabinet meeting this Friday. Let me just read you some of the messages that are coming through now from people. So Ernie says, so am I able to go off camping at the end of May? Someone else says, Kevin at Manly, so arrogant of the NRL to set a date without consulting the Premier. I love going to QPAC. Why can't they open soon, as a theatre is an important part of society? And so you see the creep of habits and behaviour, that expectations change when something like the NRL comes back on board. What do you think? Should rugby league be played at the end of May?
Yeah, I think those comments really highlight some of the issues we face here. I'm completely cognizant of the fact that it needs to be balanced. We need to take into account a number of different agendas and, basically we need sport. I can't wait to watch football, as much as anybody. But we need to make sure we do it right, because if we go too fast or don't do things right and there's some complications in terms of extra cases or contributing to a spike, or it contributes to some mixed messaging and issues in the community, then we're going to do more harm than good. So I'd just like to think, and I'm not saying this hasn't happened, but I'd just like to think that there's been proper consultation and consideration of all of the different perspectives that need to be taken into account before any firm decisions are made. And I know the AFL, for example, are taking into account a lot of this consideration, and I'd like to think the NRL are as well, but I guess that remains to be seen to a degree.
It comes as a kind of a wave of restrictions are lifted, right? We know from Midnight Friday people can go for drives, they can go for picnics. The consequence of that means that things like the lawns at Howard Smith Wharves will reopen on Saturday. Now, they're going to have social distancing or physical distancing in place, but it's still going to be a big bunch of people sort of congregating on one spot. Tennis Queensland will allow the reopening of courts across the state for community play this weekend. Some of the limits on things you can buy at supermarkets are lifting. Do you think that the timing and the messaging of that is right?
I do. I mean, I think the way to look at all these things is it's definitely reward for effort. You know, we've had the right restrictions recommended and people have done a fantastic job. I think that's really clear. Our numbers are astonishing and better than most of us predicted we'd ever get to. I guess what we need to remember now, though, is this doesn't mean it's a free-for-all. And I'd like to think that what we've been through the last few weeks and months will change behaviours in a lasting way. And so things like social distancing and hand hygiene will become automatic. But if we relax too far and see this first iteration of relaxations as a opening of the door to do whatever you like and kind of ignore the rules from here, then we will see a spike in cases and we will have to go backwards significantly in terms of restrictions. So as I say, everyone's done a great job and this is the reward for that, but we just need to keep in mind that we can do what we're allowed to do and not push it just yet.
Paul, you never know what you're going to get on the text line. You know what I've got now is a whole heap of people who are volunteering to be the test body for your vaccine. Have you got enough volunteers? Because Catherine at Underwood says, how do you volunteer? Love to help. Finney says, please ask Paul how to volunteer for the corona trial. Got enough people?
What I might do is share our Facebook and the phone number details with you afterwards, and perhaps they could be posted on the channels, because we're always looking for volunteers, and without enough volunteers these sort of trials can't happen. So it'd be great if people that are interested do register.
All right, you got to love that altruism and dedication. You can call now if you've got a question for Associate Professor Paul Griffin, Director of Infectious Diseases at the Mater Hospital, 1300 222 612, or you can send a question by text 0467 922 612. Maggie's called in from Brighton. Good morning, Maggie.
Good morning.
What's your question for Paul?
Oh, hi, Paul. My question is, I bought some masks online from a shop in Sydney, and I bought them specifically because they're N95 masks, and I have a lung disease. But I suspect that they're not really, because they just don't feel very effective. I can feel air coming out under my chin if I exhale. So I'm wondering how you tell if an N95 mask is actually what it says it is, and what you can do if it's not.
Yeah, good question. It's an issue we're grappling with because, unfortunately, there's been a lot of claims about a lot of products that may not necessarily be accurate, and it's always challenging when you get things online or imported from overseas to know whether it's legitimate. What we talk about in the healthcare setting with N95s is what we call fit checking. So you need to make sure those N95s have a really snug fit around your face, and then if you breathe quite quickly, you shouldn't feel air escaping, because that does mean that it's not sealed properly. So if you still do, it may not be the right type of mask, but it also might not be the right size. N95s to really work need to be sized correctly as well. So, and the big thing I'll say about masks is if they're used properly, they might offer a slight bit of additional protection, but it still is the social distancing and the hand hygiene that are the main ways we're going to stop this being passed on.
Thank you, Maggie. Barbara from Alderley says, what happens to COVID-19 when someone dies? Does the virus stay alive or die?
The virus will eventually die. It requires a host to remain viable. That's not immediate, so it is something that we need to take into account in our hospitals to make sure that the infection control precautions we're implementing do persist even to that stage. So, but it will eventually not survive, yes.
Sorry, I just had a grim thought then, because I was thinking about the body count in countries, well, in first world countries like America, where they have morgues, although in some cases, like in New York, they didn't have enough space. Could there be a wave of infection from those cadavers?
It's possible, but if we think about how it's transmitted in terms of that droplet transmission, you really need something to propel or expel those droplets, so coughing, sneezing, even talking, singing, something. And I guess one thing, whilst we still might be able to detect live virus from people that have unfortunately succumbed, they're not going to be doing any of those things, so the risk is pretty low. And typically when we actually, and it's a bit of a gruesome subject, I guess, but typically when we're handling anybody who's unfortunately deceased, we take a certain amount of precautions anyway, just to make sure we're protected from other viruses, for example.
Yeah, it is grim, but it is the reality that is facing the world right now. The other news that was, I think, worrying to lots of people came out of London. This is health officials in Britain warning about a coronavirus-related syndrome that they fear is emerging in children. What do you know about that, Paul?
Yeah, so I guess at the moment with so much coronavirus around, anything that's observed is immediately potentially linked to coronavirus. So the sort of syndromes they're talking about in terms of SIRS syndromes and Kawasaki syndrome and those sort of things are syndromes that aren't new and can be caused by many things. And so it's quite possible that they're linked to coronavirus, but I don't think we're at the stage where we know for sure that they definitely are in these circumstances. And, we know coronavirus is a virus that can cause a large number of different things. Still most typically the respiratory syndromes that we're familiar with. So it's quite possible it's causing these other things, but I wouldn't be alarmed by that, because obviously if we take these measures to control it, we don't need to worry about any of those syndromes.
Associate Professor Paul Griffin, the Director of Infectious Diseases at the Mater Hospital. Are we live on Facebook at the moment as well? Yes, we are. So you can see Paul and you can ask questions on Facebook as well if you want to type one in there. ABC Brisbane Facebook. Judy says, are people becoming immune to the virus yet?
Look, that remains an excellent question. And the short answer is we think people will develop some immunity, but we don't understand enough about it to consider things like trying to get herd immunity or to create immunity passports, for example. So it's likely the vast majority will get some immunity. We don't know how to test for it, though, so we don't know how to test who's got it. We don't know how long it lasts. We don't know what proportion of people will be protected. So there's a lot of unanswered questions that we're all working quite hard to address yet. But we just need to make it clear that while it's likely people will get some immunity, the concept of trying to get herd immunity through disease is one that's just not going to work.
Raymond says the advent of a vaccine won't eliminate the virus, will it? Will it be similar to the flu vaccine?
It depends a little bit on the vaccine and how well it works. And it's probably the case that it won't eliminate this. But what we'd hope is if there's good uptake of the vaccine, it's a vaccine that's as successful as we hope it will be, then we won't see widespread transmission anymore. We'd perhaps see just pockets, and particularly in people who, for whatever reason, aren't vaccinated. So it'd be one of those things that will depend a bit on how it's used as well. I guess a bit like our app, we've got a fantastic app, and if people use that, it'll be a really powerful tool. If the uptake is poor, then it won't work so well. So, and I think in that case we've seen excellent uptake, so I think that's going to help us a lot.
Peter from Alderley says, are upper respiratory spray immunisations being trialled?
Yes. So there's a number of different ways we try to make vaccines. Most of them are through trying to get some kind of thing off the surface into a thing that looks like a virus and injecting that. So the two that we'll be trialling soon have no live virus in them. But a strategy for immunisation is to get a live attenuated or an inactivated vaccine. So a virus that is switched off from causing the problems, but that we can then give to people as a vaccine. And because the virus usually enters through the respiratory tract, it makes sense to trial that. So there is definitely at least one reputable vaccine I know about that will be a live attenuated intranasal vaccine, but that's still a little way away yet.
Great question, Peter. Thank you. Just while we're on trials, Donald Trump and Clive Palmer would like more trials with hydroxychloroquine. And in fact, if you pick up any newspaper today, again, another 3 full-page advertisements from Clive Palmer in bright yellow. We heard from the Australian Medical Association earlier this morning, who fairly firmly said, don't take your medical advice from an advertisement in the newspaper. But Clive Palmer has purchased 32,900,000 doses of hydroxychloroquine for Australians. Will that be helpful, Paul?
So in all of medicine, we want to do things that are based on really good evidence. And that's why, for example, when I've been talking about the vaccines, we talk about needing all this data to move into people and then needing all these phases of trials to prove that it's both safe and successful before we move forward. And I think with this, with COVID in general, there's been a lot of claims about different therapies, but a lot of them have not been supported by sufficient evidence. And I think hydroxychloroquine is one that there's perhaps enough evidence to justify large trials, and they're ongoing, but we do not have the results of those to be able to say it is or is not effective. And in fact, from a number of small trials, there's been a suggestion that the potential risks might outweigh those benefits. So it's definitely not a therapy that's supported by the evidence yet. I think there's justification for trials, but we need to wait till those trials are done before we know.
Is there justification for stockpiling 32 million doses?
Yeah, I guess it's a little bit like stockpiling of anything that we saw. There's unintended consequences and potential harm through stockpiling things. Hydroxychloroquine is a medicine that's used by a large number of people for all sorts of different conditions, and those people now are unfortunately having issues getting their medication that they need for evidence-based, well-diagnosed, well-recognised indications. So I think any large intervention can often have consequences that are unintended, and I'd encourage people not to potentially stockpile things like this because we just don't have enough data yet.
The other idea that's been injected into the national conversation was by the Greens yesterday. They've pitched a public pharmaceutical company. I know that's slightly outside of the realm we normally get into, but I'm interested as an infectious disease specialist. What do you think of the idea of a public pharmaceutical company, government-owned?
Yeah. Look, was that really around trying to fund and supply more medications? Was that where they were coming from with that?
Yeah, because the suggestion was that vaccine research is driven by profit. The idea that perhaps coronavirus vaccines have been investigated previously and then not pursued because of a profit agenda.
Yeah, I can speak to that. So a lot of people are saying we won't get a vaccine for two reasons. First of all, that the common cold doesn't have a vaccine. But if you look at the complications that arise from that, they're so few and far between that, even government competitive grant-based funding, you just wouldn't get that for an intervention like the cold where there's very little consequence. So I think that's why there's not been enough research to get to that point with those, as well as the fact that the common cold comprises many different viruses. It's not a single coronavirus that perhaps could be targeted. And around SARS, we were able to effectively get on top of SARS with infection control interventions, the things that we're recommending now. So we didn't get to the stage where we needed a vaccine, but there were quite a few that looked quite promising. So it's not like that didn't progress and get pretty close. It just didn't then need to happen from there. So I think vaccine funding, while some people will see it that it's driven largely by profit, there are a lot of philanthropists and a lot of government bodies that also fund vaccine development, and we've seen them come on board a lot in recent times. So, the majority of the vaccines that I'm involved in are actually funded not necessarily by private companies, but by those large groups. So I don't know that's always necessarily true.
Dennis wants to know if it's safe to receive overseas parcels.
Short answer is yes, because the time taken to get here, if there was any virus on those, it would have gone away by then.
Charles says, with different countries managing this pandemic differently, how will countries eventually open up to each other?
That's a really good question, and one we don't have a simple answer to. I mean, I think we're seeing a progressive relaxing of the restrictions here, which is great, but I think the concept of overseas borders opening up is still one that's not on the agenda just yet. We'd need really good control in a number of countries before that was considered, and I think that's a little way off yet.
Someone on text says, I've been waiting the past 48 hours for test results to come back. How long should it take?
It's a bit of a generalisation, usually within a day. Depends a bit on which laboratory and the individual volumes there. I think you heard in the news that the test volume is enormous. We're doing a great job of testing a lot of people. It's around 2,000 a day. So some of the labs are a little bit saturated. I would encourage following up with where you got that test from, though, if you don't get something back in around 3 days.
Madonna wants to know, what are the ingredients in the vaccine?
So it depends a bit on the individual vaccine. Our first one, the Novavax vaccine at Nucleus Network, has obviously the virus-like particles in it, the nanoparticles which form the vaccine, and then it has a very small number of agents to make sure it's stable. So, but obviously they're all part of the clinical trials. There's a lot of really good evidence for all of those as well. So there's nothing in there that we're concerned about. I know there's a lot of discussion around the things like mercury and thimerosal, and we know that, as I said, any ingredients in that would be definitely safe, or we wouldn't be going to this
Steve's
trial.
Watching you on Facebook Live this morning and says, are there different strains of COVID-19? I've heard there's a different strain in Europe.
There are definitely some subtle changes that are being found. I don't know that we'd definitely say there are definitely different strains, but that's all being looked at now, and I think it's looking like it's a virus that has the potential to change a little bit, but hasn't really changed too much yet.
I had a conversation with some people the other day about third world countries because it came off the back of the idea that, it's a real privilege to be able to isolate if you have a safe home with the space to isolate. Why are we not seeing in some countries mass transmissions of the virus and deaths?
Yeah, there's healthcare systems do underpin a little bit how well we were able to pick up cases and how well we report them. So Australia has a great system. We're doing lots of testing, and anyone who's positive is captured in numbers and reported well. I think a lot of countries don't necessarily have those systems, so some countries still aren't testing widely. So there's likely to be cases that just aren't identified, and people may be getting sick or unfortunately dying without knowing that that's what it's from. So the healthcare system really underpins the numbers as well. So that's when we compare different countries, you have to look at all of those different factors in terms of testing and how widely that's happening.
But given that a country like America, the death toll is something like 57,000 people now, Wouldn't we know if that was happening in somewhere like India?
The short answer is we might not. So I would think if it got to that stage, we probably would. But I think it's really hard to compare countries based on all those differences in healthcare and how things are reported and the volume of testing. And, I think India is one where there's probably a few more cases that are being reported, but they're clearly not in the United States. I think the United States is really unique at the moment in terms of how widespread their transmission is.
Yeah, why has it been so horrific?
I think there's a number of factors that will contribute there, some behavioural ones, some issues potentially with leadership and some recommendations that came from the top. And, I think, and it's really hard, there's no one single thing. I just think they didn't really take it seriously enough when it was knocking on the door, and it just then went too far before they could control it.
And India, a country of 1.3 billion people, is in lockdown, arguably a stricter lockdown than the United States of America. We should just say in terms of leadership, Paul, and look, I won't assume, should you inject yourself or consume any bleach or disinfectant?
That would be a big no.
Great. Just back to Clive Palmer momentarily. Kay on the Sunshine Coast says, Paul, what is the shelf life of Clive Palmer's investment in those doses of hydroxychloroquine?
Yeah, I'd have to double check exactly what the stability is of hydroxychloroquine. I believe it's a few years, so it will have to be used within a small matter of months, but it is only a few years, I believe. So, and again, I'm not certain of that, so there may be people that can correct me out there, but it's certainly not going to be indefinitely. So. Yeah. And
to go back to Dr. Chris Sapala from the Australian Medical Association, who also made the point this morning that perhaps there are countries who could do with malaria medication right now. Henry says, what about quinine? Is that being tested? What's quinine?
So that's another anti-malarial, and no, not really. So chloroquine and hydroxychloroquine are the two malarials that are being talked about with COVID, but I haven't heard of any work on quinine yet.
Okay. Paul says, could you explain why infected people apparently have blue lips?
Yeah, I guess if people have low oxygen levels, they could potentially have that. It's not something that would be particularly common, though, and would only potentially occur in the sickest people before they got treatment. So not a common thing to look out for.
Carol wants to know, how do we know how long before this will all go away?
Great question. I wish I had the answer. And, the big thing about all these predictions and all this modelling is we're in control of that. So, it really depends on what everybody does. So if we keep doing all the right things, it's going to be around with us for a while, but the impact will certainly be reduced. So in terms of when we get rid of it, it really requires an effective vaccine for that, I think. So we're a little way away yet.
Carol, that's the question or the hope on everyone's mind. And just finally, and you don't have to go into depth on this, but Sean from Wollongabba is wondering, do you ever think about the psychology of people who peddle fake remedies and miracle cures? Does it get in the way of your work?
It absolutely does, and it causes a lot of confusion out there. And, from reputable colleagues of mine through to Trump, that misinformation does definitely do a lot of harm. So I think we all need to be a bit moderated in what we say, be cautiously optimistic with anything we're working on, and just wait for the evidence before we put too many conclusions out there.
Good to see you again, as always. Thank you so much.
Thank you.
Associate Professor Paul Griffin, the Director of Infectious Diseases at the Mater Hospital, also working with the University of Queensland, who have passed that other important milestone looking at antibodies to neutralise the virus in preclinical testing. 2 weeks' time from now, though, is that big day for Paul and his team. Human trials as we inch our way closer to protection and hopefully normality. Stay with me after the news. We're going to buy a house. Who buys a property in a pandemic? You'd be surprised.